Dear colleagues, okay. Dear colleagues, it's a great pleasure to welcome you all this evening. We are honored to have with us three of the most distinguished names in European endoscopic surgery and GESEA. Professor Sarıdoğan, the current president of ESKE, Professor Grimbizis, former president of ESKE and the board of the directors, and Professor Vasilis Tanos, the president-elect of ESKE, who will assume this presidency this year. These three outstanding experts will share their knowledge and experience on adenomyosis, covering its diagnosis, treatment options, and management in infertility. I would like warmly welcome all three speakers and thank them for accepting our invitation and taking the time to be with us today. At the end of the presentation, we will have an extended discussion session. Participants are welcome to ask questions either verbally by raising their hands or in writing through the platform. Once again, I would like to express my sincere gratitude to our distinguished speakers for joining us and contributing to this important educational event. I wish all of you an enjoyable and highly productive webinar. Thank you. Now the first speaker, Ertan Sarıdoğan, will explain the diagnosis modality of the adenomyosis. Yes.
Thank you, Professor Pabucu. Thank you for the kind invitation. And I would like to start by thanking you and the Society of Reproductive Medicine and Surgery of Turkey for organizing this webinar. I will cover the general aspect of adenomyosis, diagnosis of adenomyosis in my talk. And then we will hear more about the fertility-related aspects of adenomyosis in the following two talks. So adenomyosis obviously is presence of endometrial tissue within the myometrium, and quite often you see this picture widely available on the internet. I've seen many people using the same picture. So this is a typical section of a uterus with adenomyosis. You can see mostly on this side of the uterus, but it affects the fundus and the opposite wall as well. So in terms of diagnosis, obviously we need to be familiar with the anatomy of the uterus, anatomical layers. So it obviously has a serosa, thin layer serosa, and myometrium. And because adenomyosis is the disease of myometrium, so we need to recognize the layers of myometrium. It has an outer layer, or in Latin, stratum supravasculare, then the middle stratum vasculare, the vascular layer, and then the inner myometrium, stratum subvasculare, or what some people call is archimetra. So the embryologic origins are thought to be different between the inner myometrium and the other layers of the myometrium. And we obviously have a endometrium. It is important to recognize the endometrium does not have a basal lamina, so that it's one of its features, and it's probably one of the reasons uterus is vulnerable to developing adenomyosis. So this is the ultrasonographic representation of these layers. So endometrium is there in the middle. Then, well, it is echogenic. Then we have the hypoechogenic inner myometrium, or what we call as the junctional zone. And then we have the middle and outer myometrium with the vascular layer. Quite often in clinical practice, middle and outer myometrium is considered together as outer myometrium because they have similar features. And adenomyosis obviously is thought to develop due to a number of mechanisms, and these include invasion of the endometrial basilis into the myometrium, and perhaps this is facilitated by repeated microtrauma of the junctional zone induced by tissue injury and repair. And then there are obviously possibilities of de novo metaplasma from the stem cells, and There is also the concept of invasion from outside, especially for adenomyosis of outer myometrium, and a number of genetic, inflammatory, immune, angiogenetic responses are thought to be involved. So I'm not going to go into those. Again, going back to the anatomical description, so that the endometrium is there, the inner myometrium, junctional zone, has dense, smooth muscle cell parallel to the endometrium, together densely compact in connective tissue, whereas the outer layers of the myometrium have more extracellular space, so loose, smooth muscle arrangement, and they are still parallel to the endometrium or serosa. So these are summarized so that there is more smooth muscle in the inner myometrium, more connective tissue in the outer myometrium, and then there is more extracellular tissue in the outer myometrium. And these determine the appearance of the myometrium on ultrasound and MRI examinations. Again, this is the close-up picture of the same thing. Inner myometrium and outer myometrium. Outer myometrium is loosely arranged in terms of smooth muscle cells compared to the inner myometrium. And then when there is adenomyosis, then some of these change. The myometrial smooth muscle cells become a bit more disorganized. They don't necessarily lie parallel, and they have more cytoplasm. You can see the endometriotic glands and stroma within the myometrium itself, either in the junctional zone or in deeper layers, as you can see here. So how do we diagnose these? The diagnosis can be based on histology, and this was the case when we only diagnosed adenomyosis at hysterectomy, and the histopathologists said that if the myometrial invasion was more than 2 or 2.5 millimeter away from the endomyometrial border, then that was sufficient for diagnosis of adenomyosis. Some histopathologists describe the distance as one high power field under the microscope, and then the others described as one low power field under the microscope. But there is no overall consensus with histological diagnosis. So these days, obviously, this is a bit old-fashioned, the histological diagnosis. We look at, especially in infertile women, the diagnosis based on imaging, and ultrasound is the most important imaging component. So the group of MUSA, they described sonographic features of adenomyosis in this landmark paper in 2015. And the paper was updated in 2022. So these are the revised MUSA criteria for adenomyosis. So that describes two groups of findings on ultrasound. One is direct features. So these are direct appearances of adenomyotic lesion, including myometrial cysts or hyperechogenic islands, and echogenic subendometrial lines or buds, as you can see here. And then there are indirect features, and these are not necessarily direct adenomyotic lesions, but the changes as a result of adenomyotic features. This may be asymmetrical thickening of the myometrium, or fan-shaped shadowing, or globular uterus, or translesional vascularity, or irregular junctional zone, and interrupted junctional zone. So let's look at these individually. So myometrial cysts involve presence of endometrial tissue, perhaps with a bit of hyperechogenic surroundings around them. And these are indicative of adenomyotic lesions directly, as you can see in these examples pointed by the arrows that we can see. The second direct feature is hyperechogenic islands. They look brighter within the myometrium. They are not connected to the endometrium itself, so hence they are called islands. And they are, as you can see, irregularly bordered tissues on ultrasound scan within the myometrium. And the third direct feature is the lines and buds that are connected to the endometrium. So these are described as subendometrial lines and buds. As you can see here, again, these are indicative of infiltrating endometrial glands and stroma into the myometrium, and there are ultrasound findings directly. So in the figure here, in A, you can see the lines, and then here there is a bud, and then there is another bud here in B. Again, lines and buds can be seen in these examples. So that the rest are indirect findings. So these are not necessarily confirmative of adenomyosis on their own, but they need to be considered together with the direct findings. Asymmetrical thickening is one of them. If adenomyosis is mainly affecting in one of the myometrium, one side of the myometrium, that side may be thicker compared to the other side, and this is usually an indirect finding of adenomyosis. And same issue, also the uterus may look globular. It's like more round shape compared to its typical morphology. And this is also thought to be an indirect sign of adenomyosis. And irregular junctional zone, obviously this might be due to a number of other reasons as well, but irregular junctional zone, without seeing those lines and buds that I mentioned earlier, that is also a possibility of adenomyosis, an indirect sign. And fan-shaped shadowing, that this is a typical sign we see. The presence of adenomyotic lesions actually create this shadowing, which looks like a fan, hence the term fan-shaped shadowing. And translesional vascularity is important, especially when we are looking at focal adenomyomas and differentiating them from myomas or fibroids. Because when you do Doppler, when you put the Doppler on ultrasound examination, with myomas, the vascularity will be around the lesion, and you wouldn't necessarily see vascularity going through the lesion. And if you're seeing vascularity, vessels going through the lesion, then that is more suggestive of adenomyosis, as you can see in these examples. And interrupted junctional zone, again, here that we can see the endometrium here and the junctional zone around it, but it's interrupted by some irregularity. And then also there is a myometrial cyst as well. So these are typical indirect signs of adenomyosis, and they are very easy to identify to the experienced eye, making diagnosis of adenomyosis more reliable by ultrasound scans. So the second tool that we have is MRI. MRI is also a useful tool. Perhaps before the development of ultrasound findings, MRI was perhaps the main tool that we had for diagnosing adenomyosis. And to understand MRI, we need to understand again the content of the layers of the uterus. So the endometrium has high water content, so it looks bright. And then the junctional zone has less water content, so it looks hypoechoic. And then the outer myometrium has something in between junctional zone and endometrium, so that it's brighter than the junctional zone, but less bright or echogenic than the endometrium itself. So there are many features of adenomyosis on MRI, but I've highlighted the most important ones or commonly used one. So the most frequent one is the thickening of the junctional zone. The radiologists usually use the 12 millimeter cutoff, but this in itself is not on its own, not a diagnostic feature. So one needs to find other parameters. So on T1 sequences, they may show as hyperintense foci corresponding to areas of hemorrhage. And then on T2 sequences, they look like low signal intensity lesion, with or without punctate high signal intensity foci scattered through the lesion. And then some striations. So we'll see some of these examples. There may be in different forms, so that this is A is indicating adenomyosis of the inner myometrium. And then again, inner myometrium, but it's asymmetrical. It's only on the anterior wall, not on the posterior junctional zone. This is a symmetrical inner myometrium adenomyosis. And this is more diffuse adenomyosis in D. There is a bit of asymmetry. Again, the posterior myometrium is thickened more compared to the anterior myometrium. And this is symmetrical diffuse adenomyosis. There is thickening on both sides. And this is solid focal adenomyosis. And this refers to the G, refers to the cystic focal adenomyosis. And sometimes adenomyosis may protrude into the uterine cavity, submucosal adenomyosis. And then there is the outer external adenomyosis, so that this is focal external adenomyosis in item I. And then in J and K, we see the what we call as adenomyosis of the external or outer myometrium, which is usually found together with deep endometriosis affecting the bowel or bladder, as you can see in these examples. So examples of these, so that this is showing diffuse adenomyosis, but it's asymmetrical. It's more on the posterior wall compared to the anterior wall, with like hyperechogenic punctate appearance within a thickened myometrium. And this is a cystic focal adenomyosis in the right lateral wall of the uterus. And then you can see the cystic appearance next to the uterine cavity, not connected to the uterine cavity. Obviously, one differential diagnosis with this will be ACOM, which is somewhat different than adenomyosis. And then focal adenomyosis of outer myometrium that affects not the junctional zone, but the outer myometrium. And quite often it is found together with endometriosis, endometriosis affecting the rectum or rectosigmoid that we can see here. There is again adenomyosis of outer myometrium. Junctional zone is not affected, but there is endometriosis affecting, deep endometriosis affecting the bowel that we can see in these two examples. So, and then same thing can happen on the anterior wall as well. And when we see bladder endometriosis, quite often it is associated with adenomyosis of the anterior myometrium. So these are the main findings of adenomyosis on MRI. Hence, using a combination of ultrasound, either on its own or in combination with MRI, we can diagnose adenomyosis without waiting for the histology result following hysterectomy. With that, I would like to finish and invite you all to our next Congress, which will take place in Krakow in early October. And I would like to see as many of you as possible there in person. Thank you very much.
Thank you, Professor Sarıdoğan, for excellent presentation. We learned a lot of things. So, do you think we should educate ourselves to comment MRI findings with ultrasound? Because sometimes we are confusing. Only radiologists are explaining the pathology. What do you think?
No, it is. I think it's a very useful skill to learn. I have actually over the years, by reading and talking to the radiologists and looking at the images regularly, I now look at all MRI images myself and find it very useful, particularly for surgery in general. So yes, we should have basic skills to read the MRI images ourselves. And for that, I think the principle is to learn what the difference between T1 and T2 sequences so that we can interpret the images.
Okay.
There is, I think, one more question about hysteroscopy and hysteroscopic findings. So the first one is, are there hysteroscopic features? Yes, there are possible hysteroscopic features, and these usually refer to prominent gland openings so that we can see dilated gland openings. And occasionally we see hemorrhagic material draining from these. That's the most common symptom, but sometimes the overlying endometrium can become so irregular, giving an appearance of intrauterine adhesions. And sometimes, people diagnose that appearance as these scarred endometrium, although it is usually due to the adenomyosis of the inner myometrium close to the endometrium. So yes, it is possible.
Question is, in absence of direct features, but only indirect features are present, can we diagnose adenomyosis?
Depends on the number of indirect features, so that if you have only one, it may be perhaps less reliable. But if you have a combination of indirect features, then that will be more convincing. There is no rule as to how many you need to have. But if you have two or more indirect features, then that would be a kind of more probable diagnosis of adenomyosis.
During the hysteroscopic resection of adenomyosis with hysteroscopy, I think it is difficult to resect the pathologic or healthy tissue. What do you say?
Well,
Because
obviously, it's a big challenge, and then I think hysteroscopic management of adenomyosis is probably still skill which should be limited to experts, limited number of experts, because it requires a high level of experience, and if it's not carried out properly, it can cause significant damage to the endometrium, and you may end up with a scarred endometrium, scarred uterus. So the problems are that adenomyosis is not a localized lesion. It's not like removing a submucosal fibroid, which has clear boundaries. So you can actually find the pseudocapsule and resect the fibroid and preserve the surrounding myometrium and potentially overlying endometrium as well. Whereas with adenomyosis, we don't have that luxury. So kind of you resect within reason whatever you think is adenomyosis. Perhaps it's easier when there is an obvious adenomyotic cyst protruding into the cavity. They are obviously easier to treat. You can, as long as with ultrasound guidance, you can locate and open into the cyst cavity, it is usually easy to resect the cyst wall successfully. But kind of more solid infiltrative adenomyosis, I think is a lot more challenging in general, hysteroscopically.
okay. I think there is no more question. Yes. How to minimize trauma to endometrium during hysteroscopy, biopsy, or surgical evacuation of pregnancy tissue?
Okay. Yes, it's a long question. Obviously, with biopsy, if you're using less traumatic approaches like a PIPEL, for example, plastic biopsy, then the trauma to deeper endometrium and myometrium is less likely. If you're using metal threads, especially if you're harsh, you're more likely to cause damage to the junctional zone, and this may be one of the reasons why adenomyosis is more common following DNC procedures. For pregnancy-related issues, obviously, there is the debate whether retained products of conception should be removed with suction evacuation or at hysteroscopy. And I think the jury is out on that for the time being. We would all like to think that hysteroscopy is probably better, but then especially for first-time interventions, there is the problem of excessive bleeding obscuring our views and making the procedure perhaps less reliable. I think we need to wait a little longer to see if hysteroscopy is better for treatment of retained products compared to the surgical evacuation. This, I would say one exception is that if a patient already had surgical evacuation and there are retained products, and then in those patients, it is sensible to do hysteroscopic removal instead of repeat surgical removal. That is my practice in general.
Is there any special time during the endometrial cycle to resect adenomyosis?
Okay. I think the thinner the endometrium is, the better. So early
Phase
cycle.
of proliferative phase, huh?
Yes, early proliferative phase. Because otherwise, you have the thicker endometrium to get through, and then endometrium becomes edematous towards the end of the proliferative phase or in the luteal phase in particular under progesterone effect. And hysteroscopic surgery, any hysteroscopic surgery becomes more difficult in the luteal phase.
Right. Due to thickness of endometrium. Thank you very much, Professor Sarıdoğan.
Pleasure.
Introduce the second speaker.
Yes, thank you. So as the second moderator, so it's my pleasure to introduce our next speaker, who doesn't need any introduction. He's one of my predecessors, a former president of the European Society for Gynecological Endoscopy, but is now the chair of board of directors of European Society for Gynecological Endoscopy. He'll be providing the next presentation. Grigoris, the microphone and screen is yours.
Thank you very much. Thank you very much for, Rekai, for your really very honored invitation. I would like to take the opportunity to congratulate for this series of webinars that are really very didactic for all of us, because, even the speakers, they always learn something during the discussion or the presentations of, the others. So I would like also to thank Erdan for, his kindness to introduce me with, those really, let's say, this introduction. So I will share my screen. Is it okay? I think it's okay.
Yes, we can see your screen.
Okay.
If you can move to the
Now it's
slideshow.
okay.
Then.
Okay. So, my presentation will focus on the adenomyosis surgery, and mainly to enhance fertility, because if we, are thinking about uterine preserve surgery, this, is probably directed to preserve uterus for fertility reasons. So I don't have any commercial interest to declare. I will not stay to that slide too much, because, it's actually, the definition of adenomyosis, which was presented previously. Adenomyosis is the presence of endometrial glands and tissue into the myometrium. And also another very important finding is the smooth muscle hyperplasia of the adjacent myometrium. And this is also an important histological finding. Of course, I will not stay also to the forms, because, those were presented very in details by Erdan previously. So I will go on to my presentation, and, I will start actually discussing if adenomyosis is related to infertility or not. This is the first question. if it's related, then we have to think about, conservative or surgical treatment. So the first study, clinical study, was published in 2010 because, in the early 2000s, actually, we had the tools to diagnose, as presented by Professor Saridogan before. We had the MRI in the beginning of this century and also ultrasound, 3D ultrasound. So we were able to diagnose adenomyosis, with imaging techniques, which was not the case before. So in this study, they compared the adenomyosis group with the leiomyoma group, and what they discovered is that the adenomyosis group, more frequently you can find infertility, endometriosis, which is also another disease of ectopic endometrium, and also, pain. This is a very important for me population study published by the Japanese group of Yamaguchi, and what they found is that the women with adenomyosis, they have their births, quite late in their life compared to the general population. That was an indirect finding that something is happening, in the group of adenomyosis, and in the same study, what they found actually is that apart from the maternal age, in the first, child, the women with the adenomyosis, more frequently they had only one child, and also, a lot of them, 30% of them, they needed sterility treatment and also the application of ART techniques. So that means that infertility was behind, the women with adenomyosis. So if we take the IVF as a paradigm, what is happening in the results, the women with adenomyosis are associated with a 30% decrease in the likelihood of pregnancy, and also a twofold increase, in the likelihood for miscarriage. So that means that there is a problem in the achievement and the evolution of pregnancy. And another very interesting finding was that in cases of women with deep endometriosis, so if you treat them by surgery, and those women, they were directed, to IVF, you can see that those women that they had also adenomyosis, together with deep endometriosis, they have, worse result. They have a 70% decrease, in their likelihood to achieve a pregnancy. So there is a problem of infertility, in women with adenomyosis. And of course, those women that they have, diffuse adenomyosis, which is probably something that you can expect, they have worse reproductive outcome, compared to those with the focal, or those with a tubal factor infertility. And those women that, the glandular element is more prominent, in the MRI findings, they have worse results. So if you have, more glandular element in the myometrium, this is related to worse reproductive outcome. So if that is the case, so what you can expect, let's say from conservative treatment. So you can see that, by applying ART in women with adenomyosis, some of them, they will achieve to have a pregnancy, let's say between 40%, something like that. So that means that there are women, with adenomyosis, they cannot have a child, with the application of conservative management, and also, with ART. So the question is, if in these women, I don't know what is happening, there is a place for surgical treatment. So if we are thinking for surgical treatment with those women, for those women with adenomyosis that failed to achieve a pregnancy, with conservative, management, we have to have in our mind some general comments. First of all, what is the goal of conservative surgical treatment? Is the excision or destruction of the diseased tissue. And of course, we aim to maintain the healthy myometrium. But as Erdan told before, the problem with adenomyosis is that the disease infiltrates myometrium. And adenomyomectomy is always associated with concomitant removal of some amount of myometrial tissue. So we have different, let's say, techniques to apply in women with adenomyosis, and the classification of the different surgical approach is based on the radicality of the adenomyotic tissue removal, and also, on the preservation of the integrity of the uterine wall, and also the functionality, not only the integrity, but the functionality. So based on that, we have, a general classification of the techniques in those that we achieve complete excision of adenomyosis. And what is the definition of a complete excision of adenomyosis? Is the complete removal of all the clinically recognizable non-microscopic lesions. And, I underline that it's, the removal of all clinically recognizable lesions, because always in a microscopically, you might have, some foci in the other healthy, let's say, myometrium. And also the partial excision of adenomyosis, which is a cytoreductive surgery, and we are doing this surgery by intention. As far as, if we decide to remove all the tissue, actually this will lead, to a functional hysterectomy, which is not the case in, women that they want to achieve a pregnancy afterwards. Of course, there are some non-excisional techniques, but we will not focus in this presentation to this. So those are the techniques as we presented in a review that we published in Fertility Sterility. You have the classical technique, the overlapping flaps, the triple flap techniques, and also some others that we will present. So let's start with the classical adenomyomectomy. The classical adenomyomectomy is like myomectomy. It's, you have the same operative steps, but there are some differences. The first difference that was underlined before is that in cases of adenomyosis, you don't have clearly defined surgical borders. You don't have, a distinction between the normal tissue and also, a clear distinction between the normal tissue, myometrium, and also the adenomyotic tissue. So you have to remove, the lesion into the healthy myometrium. So you are going to the healthy myometrium to be sure that you are removing, the adenomyosis. Grasping and traction is very difficult because, of the tissue, the adenomyotic tissue type, and also you have rich vascularization in cases of adenomyosis. This is the presentation of the classical technique. Actually, you are doing after, inspecting, the uterus, and also defining where the adenomyoma or the adenomyosis is. You are doing a longitudinal incision on the uterine serosa along the lesion. After, let's say, making the incision, you dissect using either scissors or maybe monopolar diathermy the adenomyotic tissue. With monopolar needle, I think it's more easy. And also, after removing, you are suturing the myometrium, like you are doing in myomectomy. So the problem is that if you remove, the tissue together with the myometrium, you have a problem. You are at the end, you are removing part of the myometrium, and if you repair, the uterine wall, then you have a thin uterine wall. So to counteract this problem, the Japanese group of Takeshi, they proposed the overlapping flap technique. So you are doing, let's say, a transverse incision, you are removing the adenomyotic tissue. You need, let's say, you are using, the one side, let's say, to cover, the surface, and the other as an overlapping flap, to counteract, the loss of the myometrium that you did, when you are removing the adenomyotic tissue. So this is the presentation in schemes of the technique, the transverse incision through the adenomyoma, then the excision of the adenomyotic lesion by preserving, the myometrium below the serosa. Usually we preserve, as we will discuss a little bit later, the healthy part behind the serosa. And then, you remove the one side, you remove, from the other side. And finally, you see that, you put the one flap, to cover the surface that you removed, and then the other as an overlapping flap to compensate, the removal of the myometrium. So this is just to strengthen, the uterine wall. So, but this is the one technique that, we have in our hands, but sometimes you have, very diffuse adenomyosis, and in these cases, we have to do a more aggressive surgical approach, and for this, the also Japanese group of Osada presented years ago, let's say 15 years ago, the so-called triple flap technique. It's a special reconstruction, actually, of the uterine wall by overlapping different layers of seromyometrial flaps. You can see here that you are, dividing actually the uterus in two parts, entering the endometrial cavity, and then, you are removing, as you can see, the adenomyotic tissue, leaving also, behind the serosa, the healthy part of the myometrium. And after doing that, you are repairing the endometrium here, and then you are covering, the trauma, and also, you are covering the surface, with suturing, as you can see in this figure, and then you cover with the other one. This is the triple flap technique to strengthen, the myometrium. It's a very aggressive, but this is only indicated in cases of diffuse adenomyosis and enlarged uterus. Another technique is the so-called AIDS technique. It's like, let's say the classical technique, or the you are making, a transverse incision, two transverse incisions and one longitudinal. You have two flaps you are opening, and in this way you can reach more easily the adenomyotic area. Then you are removing, the adenomyotic tissue, and after removing the adenomyotic tissue, you are suturing the myometrium, approximating the traumatic surface, and also securing hemostasis. So this is, let's say, how we are doing the laparoscopic surgery in cases of adenomyosis. Another very important, let's say, type of adenomyosis, this was presented also by Erdan before, is the polypoid adenomyomas, is the protrusion actually of adenomyosis within the cavity. Those adenomyomas, the polypoid adenomyomas, are really very interesting because in some cases you have not only the typical but the atypical forms with atypia within the cells. And if you have atypia, in cases of polypoid adenomyosis, then you have to think about the endometrial hyperplasia or endometrial cancer. And this is an interesting point. So if you have an atypia in the polyp, you have, to remove, of course, the polyp, but you have to go back to remove, the endometrium just around the lesion, to resect the myometrium under the lesion, and also, to take some random biopsies from the endometrium. So this is how we are treating the atypical polypoid forms, and also, of course, for the typical ones, you are just removing the polyp. So the question is if, in the different techniques that we presented, there are some principles that we have to follow, for conservative excisional surgery. So for preoperative management of those patients, you have, it's very important to have a mapping of the lesions. And for this, MRI is probably necessary, because in this way, you know what is happening, in uterus, in the myometrium. Another thing is that it's probably better, to avoid to give GnRH pre-treatment, because if you give GnRH, then this worsens the recognition of the adenomyotic lesions borders. And you have to be prepared for intraoperative use of imaging techniques, mainly ultrasound, if you need help, to see how far you have to go. And also, you have to have some accessory instruments like uterine manipulators, methylene blue or indigo carmine, to see, what is happening in the endometrial cavity. As you can see, MRI is really very important. I will not stay into that. This was presented before, but this is, a really very important tool that give us also information, not for the myometrium, but what is happening also in the overlying endometrium sometimes, because there was a discussion about hysteroscopy, and you can see that using MRI, sometimes you have also information what is happening in the endometrium. So this is an example for the principles, the preoperative principles. This is a case of a woman with adenomyosis, and the first step is, let's say, to recognize the lesion, and for recognition of the lesion, you are using also, the MRI preoperative imaging, of the woman. You can see that in this case, we have an adenomyosis of the posterior wall, and it's easily, let's say, to see what is happening if you have also the MRI images, in front of you. So what about, the principles during the operation? Bleeding prevention and control is very important, and for this, we can consider the use of vasoconstricting agents like vasopressin or epinephrine, or, another way to achieve this is the transient occlusion of uterine arteries. So electrosurgery could be used for incision with the needle, for the sharp dissection of the adenomyotic tissue, and also with bipolar mode of electrosurgery, to control the bleeding that we had during the operation. And also, it's very important because we are speaking about cases that they would like to preserve their fertility, to use a meticulous technique with proper hydration and avoidance of foreign body in cases of laparotomy mainly. Here you can see, let's say, the injection of a vasoconstricting agent, epinephrine, and you can see, the change in the color because of the vasoconstriction. This might help you because in this way you have a reduction of the bleeding during the operation, and of course you have to hydrate. Let's say during the surgery, to keep the tissue in a better situation. What about let's say suturing and also preserving of tissue? As I told you before, it's really very important to preserve the subserous layer, during the operation, because you need this to repair the myometrium, and usually behind the serosa, 5 to 10 millimeter, this part of the myometrium is healthy, and we have to preserve this. You have to take care of the endometrial cavity. If during the operation you have an opening, you have to have in mind to repair this, and also you can repair by using let's say, absorbable sutures. And it's really very important, to avoid to have a defect, a myometrial defect, during, let's say, the suturing. Because, in this way you avoid the hematoma and you have a better, healing of the myometrium afterwards. Here you can see, how we can actually preserve the subserous layer. You can see, the healthy part and also, the adenomyotic tissue behind. So in this case, this was the beginning, let's say, of my type of surgery. At that time, I am used, let's say, to use scissors. Nowadays, I prefer, the needles. It's more easy, and you can use also the monoporal needles, let's say, to excise the tissue and, to preserve the healthy part of the myometrium. So, what is the effect, let's say, of treatment? So this is the question. So after adenomyomectomy, what you can expect is that almost 50% of the women that they will undergo adenomyomectomy, they will achieve a pregnancy, either a natural one or by ART. This was, our findings in our meta-analysis. This is, another one by the Brazilian group of Roja, and you can see that they estimated, the pregnancy rate after adenomyomectomy around 40%. And, if you achieve a pregnancy, most of them, they will reach, the live birth. And this is a more recent meta-analysis by Dueholm, published in Acta Obstetricia Gynecologica Scandinavia. And what they observed is 45% clinical pregnancy rates and, 37%, almost 40% live birth rates after adenomyomectomy, looking to all the published data of the different techniques. So another question is what you have to expect, let's say, in terms of recurrence, and what are the most important parameters that they are worsening, the results and, they increase the recurrence rate. The posterior wall adenomyosis, the presence of 2 or more adenomyotic lesions, and also, endometriosis are risk factors for recurrence. Those women, they have higher recurrence rates. So this is something that we have to tell to our patients when we are making, let's say, operation. But another really very important, finding is that if you add GnRH therapy or progestogen, dienogest, let's say, therapy after, the operation, then you reduce the risk of recurrence of adenomyosis. And just coming to conclusions, the surgical treatment of adenomyosis seems to be feasible. The radicality of adenomyomectomy is limited by the concomitant inevitable removal of, let's say, normal myometrium. And, this is something that you have to have in your mind to avoid functional hysterectomy. Polypoid adenomyomas should be treated hysteroscopically with special attention to atypical forms. Preoperative mapping is necessary with MRI. Laparoscopic adenomyomectomy could be applied mainly for treatment of focal forms, of course, for the diffuse, but the surgery is more difficult. And it's really very important that we have to keep surgical treatment as an alternative in well-organized centers, with experience in the treatment of adenomyosis. As also Professor Saritukan did, before, you are all of you are invited to our Congress, to our annual Congress in Krakow, where we will have, the opportunity to discuss more about, not only adenomyosis, but other let's say, topics of reproductive surgery. Thank you very much.
Okay. Did Ertan leave? Ertan, are you here?
Yeah, no, I'm still here.
Yeah, good.
Yes. Thank you very much, Grigoris, for this very comprehensive presentation. There are already some questions, so perhaps we can start. The first one is the gap between an adenomyomectomy and subsequent pregnancy. How long gap do you leave between the surgery and pregnancy?
I think that there is no really, let's say, widely accepted, let's say, time to wait. But for me, if you don't have any problem, during surgery, you have, to see again the myometrium in 4 or 6 months with ultrasound. And if you are satisfied, with the healing process and also the repair of the myometrium, then the woman, is feasible, to start trying. There are some publications, not for adenomyosis, but mainly for myomas. So for the risk of uterine rupture, this is not related actually, to the time between surgery and also, the achievement of pregnancy. It's, probably related to the healing process and also, the problems that we have, the hemostasis, the use of surgery, the use of energy, for during surgery and so on. So it's not the time per se, but what you have in front of you, and you have to check myometrium afterwards to, to check the healing process. And for me, 4 to 6 months is okay if the surgery is as presented before.
Thank you. So on the issue of rupture, so what numbers do you quote in terms of risk of uterine rupture in subsequent pregnancies? So that there were some numbers from Osada paper, and then they did a review in 2018, and I think overall it was about 3.5%. But I believe one of our colleagues from Istanbul, Professor Ahmet Kale, just published a review in JMIG, and his assessment is that the rupture rates are less than 1%, in fact, less than 0.5%. So do you have an opinion on the risk of rupture?
Yes, I think that, the 6% is an overestimation. Actually, there are some publications. I agree, with Ahmed, and his publication. I think that the risk of rupture is less. There are some publications from population data in Japan. There is an increased risk, of course, but, in a population-based, let's say, study, they estimated the risk, around 1%. 1.2 as far as I remember. So this is, this is the only, let's say, evidence that we have from population data. I think that 6% is an overestimation, and probably this is referred, to difficult cases, to diffuse adenomyosis, to extended surgery, to the triple flap technique, and so on. So it's, you have to personalize the data. Each patient is not the same. For me, if you are doing a classical adenomyomectomy of a focal adenomyosis, or if you are using in this type, in this group of patients, the overlapping technique, I think the risk of rupture is quite less. Of course, you have to follow, you have to follow the patient. And another thing is just, and I'm finishing, is that, the risk of rupture is not only related, to a surgery. The women with adenomyosis, even non-operated, they have an increased risk of rupture. And this is due to the changes that adenomyotic tissue has during the pregnancy. And This is important, and you have to check, I mean, the myometry during the pregnancy. There is a discussion. It's not very clear if you have to do MRI during pregnancy. This is an open discussion, but, this is another thing that we have to explore in the future.
On that, the other comment, actually, from Ahmet Kale himself, is about your opinion on non-surgical therapies like HIFU or microwave ablation. Do you have an opinion on that? He thinks that it is safer, easier, and is associated with lower risk of rupture.
I don't have any experience. I can say only, let's say, from published data. I'm not, very convinced that those type of therapies, they have lower risk because, part of the adenomyotic tissue is still there. There is also necrotic tissue. That means that you have also a defective myometrium, even, with applying those type of techniques. So I'm wondering is actually if at the end, for pregnancy, you have a better myometrial bed. And you have to take into account that during pregnancy, there are changes, because of progesterone. And those changes, they act, in the defective myometrium and also in the remaining adenomyotic tissue that we have behind. So it's something that we have to explore. We need some more data. There are different techniques. There is not only one technique. The HIFU is different. They use it also, nowadays, some Italians group, they use, let's say ultrasound, by intracavitary ultrasound to destroy. So you have different techniques with different publications. We have to wait, let's say the results. And another thing is that usually for rupture and, for complications, there are a lot of unreported cases. There are some reported cases, but actually, there are also some unreported. And the other thing is that, if somebody publishes a case report that is not representative, what is happening in the population of operated women, or those that they underwent, conservative techniques. So for me, I cannot make any comparison up to now. And still the risk, of rupture is even for more conservative distraction techniques of the adenomyotic tissue.
Okay, and actually the questions are pouring in. Maybe we take a couple more, and then we need to leave some time for the next presentation. So the next one is about place of surgery before IVF, before the first IVF, even before any implantation failure.
No, it depends. But in general, I would avoid surgery, before, the first IVF. You can have some, conservative manipulations, maybe GnRH analogs, before, maybe also GnRH antagonists. They are quite promising. We don't have a lot of results, but for me, that's something that probably will have a place in the management of women, with adenomyosis, that they will go for ART. So first, conservative, medical treatment, and then think about, surgery. Because if you are doing surgery and you are removing adenomyotic tissue, if you are going to myometrium, you don't have any way back. If you are doing medical therapy, okay, you can.
Okay. Thank you. No, I'm inclined to agree as well, that perhaps the woman should be given a chance. So a general question, not necessarily surgery, from Dr. Shafak Olgan, for all of us perhaps. So when we see adenomyosis on imaging, how do we know whether this is related to the infertility that the woman is suffering from, or is it just coincidence? It is a bystander, so to speak, in the overall scenario.
A very good question, but I think that, if you don't have any other, let's say, infertility causes, you have to think about that. If there are others, like, let's say male factor infertility, tuber factor infertility, maybe this is a factor, that impairs implantation, but not, the real infertility factor. So it depends, what we have in your hands. If there is nothing else and you have unexplained infertility, you have to think about adenomyosis as an infertility factor. If you don't and you have another, maybe this is a cofactor for implantation failure.
Yeah.
Probably.
So I suppose this is quite common, and with infertility, it is never one factor anyway, and perhaps conditions which are not necessarily significant enough to cause infertility, when they are present together, they can add up and then create difficulties in getting pregnant. So it is difficult to quantify, but I think when we see it, we need to acknowledge its presence. And if it is the only factor, then perhaps, yes, we need to give consideration to treatment. But if it is along with other factors like tubal factor, male factor, then treatment perhaps can go ahead without modifying the plan substantially. And Grigoris, the last quick question, and then I think we'll need to move to Vasilis, about polypoid adenomyosis. Would you describe, would you prescribe progesterone or GnRH agonists following surgical resection for treatment of adenomyomatous polyps?
For the typical or the atypical forms? For the atypical forms, I think that you have to treat them like, atypical hyperplasia or focal endometrial cancer. You have to give progesterone afterwards for 6 months, continuous, let's make gaze, for example, let's say for 6 months, and then you have to go back to check again. For the for the typical forms, I think that, there is no need to make anything, but you have to have in your mind always the risk of recurrence. So for the atypical, like atypical endometrial hyperplasia and also, focal cancer, for the others, like a normal polyp.
Yeah, thank you. There are many other questions, so maybe at the end of the webinar, we can come back to some of them at least. So perhaps we should move on with the next presentation. Thank you very much, Grigoris. So Professor Pabuccio, I pass the microphone and screen to you to introduce the next speaker, please.
Thank you, Green Business. It was very, very educative session for us. We learned a lot of things, and you summarized every part of the surgery of adenomyosis. Now it is my great pleasure to invite my dear friend, Professor Vasilis, with whom we have worked together for many years, who has supported and participated in virtually all of our scientific activities in Turkey, and who played a key role in the establishment of GESEA with, of course, Ertan and Isvan. Okay, microphone is yours.
Dear HI, many thanks for the kind invitation and sharing this webinar with us. Of course, we are here a group of SG people, and it gives me even more pleasure for that, joining this session. Adenomyosis is a quite interesting subject, and there are many questions and much more answers to be given. So after we heard the diagnosis and the surgical treatment of patients, I was asked to approach adenomyosis for the IVF patients. And indeed, it's a challenging situation. I have no conflict of interest and nothing to declare. We already talked about focal adenomyosis or adenomyoma and diffuse adenomyosis, and indeed it's very important to put down the correct diagnosis in order to help the IVF patients. So when you have localized disease and probably small foci, it doesn't make any problem, and the approach is more or less similar with other no-adenomyosis patients performing IVF. However, when you have diffuse adenomyosis, the situation is completely different, and we are going to focus actually exactly on these entities, our IVF approach. So we talk about MRI, and indeed MRI is very important, and it should be done to all patients that we suspect extended disease. Poorer IVF outcomes are mainly because of the junctional zone thickness, more than 12 millimeter. This is the gold standard today, although the examination can be done also with a 3D and 4D ultrasound. Diffuse involvement of the uterus or multiple adenomyotic foci also reduce the chance of pregnancy. When you have uterine volume more than 150 and 200 ml, and the posterior wall diffuse disease, like we heard from Professor Gribizis just a few minutes ago, coexisting endometriosis, and recurrent implantation failure. So women with focal adenomyosis and a normal size uterus often have outcomes approaching those of women without adenomyosis, particularly when good quality embryos are transferred after hormonal preparation. So what are the reproductive outcomes for women with diffuse adenomyosis? Generally, they have lower implantation rates, lower clinical pregnancy rates, higher miscarriage rates, and lower live birth rates compared to women with focal adenomyosis. And I call you to look at this table I prepared for you. The big differences, almost the success rate, the implantation rate, you see that is half in the diffuse adenomyosis. So the focal adenomyosis implantation rate is between 40 and 60%, while in diffuse cases is only 25 to 45%. Similarly, with clinical pregnancy rates, 45 to 65 for focal and 25 to 50 for diffuse, and miscarriage rates is much more, almost double in the diffuse cases. So what is the approximate outcome with the per euploid and favorable embryo transfer? Again, you can see here the relation and the comparison between focal and diffuse adenomyosis. Again, here we have much better results with focal adenomyosis. And what about GnRH agonist pretreatment and cryo-thawed embryo transfer? Again, here in focal is almost 65% the clinical pregnancy rate compared to the diffuse only 35 to 50% cases. Live birth rates similarly is half success to diffuse compared to focal. So how we can optimize the pre-IVF patients with adenomyosis? Of course, counseling, preconception counseling, a thorough assessment of fertility potential, and the development of an individual plan are critical. We have to evaluate the ovarian reserve, we have to do AMH and probably inhibin and any other concurrent fertility issues. Medical treatments aim at stabilizing the adenomyosis and optimizing uterine lining prior to the embryo transfer process in IVF, using hormonal support to ensure a receptive endometrium. The use of pre-implantation genetic testing may be considered if there are additional concerns regarding embryo quality or genetic issues, especially with the presence of adenomyosis and women at their 40s. So there is a meta-analysis comparing relevant to GnRH agonist suppression in adenomyosis. And we see here the study of Gonzalez in 25, focusing on IVF stimulation protocols and GnRH agonist pretreatment. They examined 8 retrospective studies. There was no benefit of long or ultra-long GnRH agonist suppression before ovarian stimulation or frozen embryo transfer. Agonist protocols perform at least as well as and possibly better. Another study, the GnRH analog pretreatment prior to frozen embryo transfer, a meta-analysis published in RBM Online. The GnRH agonist downregulation before frozen embryo transfer in 7 retrospective studies and 1 controlled trial. Agonist pretreatment before frozen embryo transfer did not significantly improve the live birth, clinical pregnancy, miscarriage, or implantation rates. And then we have another 2 studies, the GnRH antagonist from Zhang et al. In 22, a retrospective cohort and propensity score matching 282 women in this study. GnRH antagonist simulation plus freeze all and then freeze thaw embryo transfers versus long-acting GnRH agonist and fresh transfer. The live birth rate was the major metric here, and after adjustment and statistics, live birth rate or cumulative live birth rate between groups, and live birth rate was 32.4 versus 45.1% after matching, which was not significant. So the main conclusion of this study showed that antagonists and freeze-all strategy produce outcomes comparable to long-acting agonist treatment. And Gonzalez in 25, after a systematic review and meta-analysis, more or less had the same and similar results. It was antagonist higher live birth rate than long agonist protocols. And again, here was very similar, showing that the antagonists were not less inferior than the agonist. Now, if we take practical takeaway questions, you see, let's see the first question. Is a GnRH antagonist protocol inferior in adenomyosis? There is no evidence suggests inferiority. Does antagonist and freeze-all work well in adenomyosis? Yes, it works. Outcomes appear similar to long agonist protocols. Is ultra-long agonist suppression clearly superior? No. Recent meta-analyses do not support a consistent benefit. Are there randomized trials? The answer is very limited. Most evidence remains retrospective. And which protocol currently has the strongest signal for improved live birth? In pooled retrospective data, antagonist protocols showed a higher live birth rate than long agonist protocols, but confidence is limited by study quality. So let's see, we have these 3 characteristic patient types, and I would like to go through with you in these cases. So the first case, we have patients with mild to moderate symptomatic adenomyosis, mild dysmenorrhea, occasionally pelvic pain, who are still able to achieve regular menstrual cycles and are motivated to conceive. So a standard IVF protocol in these cases with standard ovarian stimulation and embryo transfer is quite feasible, valid, and it gives you more or less similar results like a patient with no adenomyosis. Of course, estrogen and progesterone are needed to optimize endometrial receptivity prior to embryo transfer. So mild to moderate adenomyosis may not significantly impact IVF outcomes, especially when a comprehensive hormonal optimization strategy is implemented. Pregnancy rates aligned with general population averages around 30 to 40% per cycle, depending of course on age and other factors. Let's move now to the more severe symptomatic adenomyosis. These severe patients, they have severe menstrual bleeding, chronic pelvic pain, and adverse effects on quality of life which tend to conceive. You have to consider here probably cytoreductive surgery. If symptoms are debilitating, consider surgery before IVF to reduce adenomyotic tissue and improve endometrial receptivity. Again, here we have patients that probably performed 2-3 IVF and they didn't succeed. And you notice by ultrasound monitoring or MRI that the disease is becoming more extensive with more severe symptoms. And of course, it shows itself that you need cytoreductive surgery. Frozen embryo transfer, consider a freeze-all strategy after IVF to allow time for endometrial recovery, a hormone optimization post-surgery, optimizing conditions to embryo transfer, either by treating patients with GnRH analogs or the new coming antagonists. The surgical reduction of adenomyosis has been shown to improve IVF outcomes by increasing uterine receptivity. And pregnancy rates after surgery may be higher, 30 to 50% in many studies, compared to those who do not have surgery. Again, I fully agree with Professor Gribizis. This should be spared for patients that they have already performed IVF in the past and they had no success. We have now the patients with recurrent IVF failures and adenomyosis, either because you lost them or the clinicians didn't make a diagnosis before, or it was more hidden disease and it was discovered later that these patients were suffering from adenomyosis as well with other probably infertility factors. So these patients, the IVF approach, comprehensive evaluation and individualized protocol should be considered. Consider further investigations to assess uterine receptivity and hormonal status. Pre-implantation genetic testing may be an option also to screen for embryo viability. In cases of recurrent IVF failure, it is critical to explore underlying issues such as adenomyosis, uterine factors, and embryo quality. The goal is to enhance implantation rates through careful monitoring, potentially including surgery or additional hormonal treatment to optimize uterine conditions. Studies suggest that addressing underlying conditions like adenomyosis can improve cumulative pregnancy rates in women with prior IVF failures. So what about patients that desire infertility preservation? That means they have adenomyosis, but they don't want to become pregnant shortly. So women that they want to delay childbearing due to personal circumstances, career, medical concerns, and wish to preserve their fertility. So the approach, oocyte or embryo cryopreservation are important, IVF and freeze embryos or oocytes for future use. Mirena also can be used in these cases to preserve the endometrium and myometrium as possible in these cases that they don't want to have pregnancy shortly. Also consider GnRH agonist to manage symptoms and pre-ovulation induction. Again, freezing embryos or oocytes allows for later use. The conditions may be better for pregnancy while addressing any immediate symptoms of adenomyosis for patients wishing to delay the childbearing. So the embryo cryopreservation success rates after thawing range markedly, but can be around 70 to 90%, depending on the laboratory conditions and patient age. Hysteroscopic resection, we heard about that before. Of course, it's important, and especially to subendometrial adenomyosis lesions can improve a lot the endometrium in these cases. And in expert hands, it showed that it's have a lot of success and chances for success. Studies suggest a symptom improvement definitely is the rate of over 75% post-hysteroscopic resection. However, the pregnancy rate is still quite under investigation, since we don't have so many studies showing this hysteroscopic resection in comparison with IVF. We heard about the cytoreductive surgery. I'm not going through again. Professor Gribizis explained it quite well, the three-flap technique, and is extensive cytoreductive surgery in those patients with severe fulminant adenomyosis. So, conclusions. The choice of treatment before IVF for adenomyosis should be individualized. Consider the severity of the condition, patient's reproductive goals, age, and overall health. Collaboration with reproductive surgeons and IVF specialists is important to identify the most suitable approach. Regular follow-up and re-evaluation of treatment effectiveness are also critical components of the management plan. And of course, thank you for your attention, and also for my turn to invite you to SK 35th Annual Congress in October in Kraków, Poland. Ready for questions now.
Okay, thank you very much, Vasilis. Today I learned that you are not expert only about hysteroscopy, you are also a very good expert in IVF. Thank you very much.
Very well.
Okay, there are some questions. The question from Cihangir Çakıcı. Cihangir, he explained the protocol of IVF, the patient with adenomyosis. And the other question, is there any benefit of performing adenomyosis resection after ovum pickup? Is that any evidence of increasing live birth rate?
Well, it depends really on the symptoms of the patient. I mean, the first concern is to save the oocytes or better embryos, if there is chance for embryos, if the patient is married, whatever. So the gonads and the embryos are important to be in storage. And after that, it is highly dependent on the expectant management. For example, you can use Mirena first for a few months and you see the effect. You can use GnRH analogs or agonists, and probably you can stabilize the patient. And then you leave as a reserve, as final option, surgery, especially in resection of the endometrium cases. It cannot be, the first option. It has to be the least option in this case.
Other question, We sometimes encounter patients where the myometrium is so infiltrated by adenomyosis that sutures simply tear through the tissue. There is virtually no structural integrity left, yes. In such cases, how do you counsel patients regarding pregnancy after adenomyectomy concerning uterine rupture?
I think we discussed before the issue of the rupture. I would like also to mention the localization of an adenomyosis. So if you have adenomyosis on the fundus, it's much more difficult to get pregnant. The implantation failure probably is higher in these patients. Also, it's a matter also of contractility. On the research base, of course, we are checking these patients, and we are a little bit mixed up with the results of adenomyosis. In some cases, we have hyperperistalsis, and in some cases, we have hypoperistalsis. So we don't know yet. We are exploring the matter, what really and adenomyosis does to the junctional zone endometrium. It seems that thickening, like you see in the MRI very well, is not always the hyperactivity of the junctional zone, or sometimes is less. And what we found also that GnRH analogs do not silencing the junctional zone endometrium. So we still see peristalsis in these cases, even after 4 and 6 months of GnRH analogs. Using the EUG, the electrouterogram that we have, we still see peristalsis, so it's not able to silence completely the junctional zone. However, we see improvements in the MRI and thickness of the junctional zone. So there is improvement by giving GnRH analogs, and also in many studies we show that we have higher pregnancy results after 6 months or even less GnRH analogs treatment, and then stimulation and embryo transfer.
If you allow me to make a comment, I think that the question, is focusing on, the integrity of, the myometrium after, surgery. So I think in these cases where you remove, a lot of the myometrium, including, the part of the inner myometrium, the surgical technique plays a key role. So I think that in these cases that we are removing a lot of, tissue, adenomyotic tissue together with myometrium, the overlapping technique is indicated. I think that, the surgeon has to take care, how he has to repair the myometrium afterwards. Another question is, is if this question is also focusing is if you remove part of the inner myometrium, just trying to remove the adenomyosis, what is the effect of this in the achievement of pregnancy? Of course, inner myometrium plays a key role, but if you have a defective inner myometrium, this is also very important. So, you have to remove this because this has an adverse effect, in achieving a pregnancy. So another, during also surgery, we are focusing on, preservation of the part of the healthy myometrium behind the serosa. But another very interesting thing is that you have, to preserve also the endomyometrium, borders. I think that this part, is really very important. There, the endometrium is like a rhizome. You have to preserve this. You don't have to remove this part of the endometrium because this is really very important for placentation. So there are, of course, it's obvious that even after the surgery, you don't have a normal myometrium, but you intend, to achieve the better results. So it's a principle to preserve the healthy myometrium, from behind the serosa, and also to preserve, the endomyometrial zone. Those two things are really very important, and also to use the overlapping flap technique, at least to offer the patient a better myometrium bed, for placentation.
Yeah.
Okay, thank you. Other question, actually, which infertile patients is the good candidates for to surgery? I think you explained it. The patient with severe hemorrhage is good candidate for surgery, huh? Vasilis, you answered this question.
Yes.
How long should we wait before embryo transfer following adenomyosis surgery? You said, and then generally we are accepting as a 6 month. Yes?
Yes, 4 to 6 months, and after, let's say,
Okay.
checking for the repair of the myometrium.
Okay. Vasilis, I want to ask you that after the surgery, after getting good embryo, for the preparation of the endometrium for towing embryo transfer, sometimes, unfortunately, endometrium is not answering with good response. And we are seeing teen endometrium, unfortunately, because of the poor vascularization.
Yes.
So what kind of the management are you advising?
Yes, there are several options in the past, and I think some centers they are still using the tablets that they do vasodilatation, like the Viagra and sildenafil, etc. This is one option. I think in a few years ago they are using it quite a lot, but the results were not so successful. Another option today, what we are trying a lot is the PRP. And also we see some improvement in some patients in combination, of course, with high estrogens. I think also some stimulation of the endometrium by just using triggering the endometrium using a scissor tip just to dissect the endometrium, and in combination with PRP. These are, I think, that the options. Now today there is a new estrogen releasing IUD. They are using it in Asia. It didn't come yet to Europe. And it's like the Mirena, but instead to have progesterone, they have estrogens. You can leave it for 2-3 months, and they claim that is efficient. I didn't use it, just from some others' experience. I think more or less these are the options.
Okay, do we have data about the effect of the GnRH antagonist pre-treatment therapy?
We have these 2 papers that they show that they are good as analogs. But if they are better, I think we are still wait for other studies to come in and show the results.
Okay, one question again is from Shafak. In adenomyosis, the junctional zone is structurally and functionally abnormal, even if we optimize ovarian stimulation and embryo quality. Are we fundamentally asking a compromised uterus to implant? Is there a point where cumulative IVF failure should prompt us to reconsider the uterine environment itself rather than the embryo?
I think this is not a question, it's a comment, and we agree with the comment. Yes.
Okay, good. And then In case of mild to moderate adenomyosis and planning to do ICSI, would you recommend decapeptyl or antagonist injection, and what is the protocol?
Well, I think both options are available. They, according to the studies, they're the same. I would use the decapeptyl. This is what I'm using, the analogs.
Okay. What is the role of letrozole in medicated frozen embryo transfer in women with adenomyosis?
I don't have experience with letrozole in the cases of adenomyosis. I don't know the other speakers if they do.
So
There is
the
only one. Sorry.
yeah, go on, you go.
No, it's Erdan. Please.
So that I think there are a couple of publications that if you add letrozole to GnRH agonists or analogs, the suppression is more effective because the idea is that letrozole prevents local estrogen production as well as the systemic suppression of estrogen, and the treatment may be more effective. So there are signs that this may be a better combination compared to using GnRH analogs on their own.
Okay. Last question is from Erol Tamergen. Do you think that atosiban infusion before embryo transfer has a positive effect to decrease miscarriage rate? Do you have any experience?
Only one study, research study, published data, and I think that, the results are not really, very promising, but, we have to wait. It's just, they tried, to give atosiban to quiet a little bit, let's say the myometrium, but I think that this is a very good idea. The results, also, we have to take into consideration as the, atosiban is an oxytocin antagonist, what are the numbers of, let's say, oxytocin receptors in a non-pregnant myometrium to have an effect. So there are several questions on this idea. So there is only one study.
And the other thing to add, I suppose, it's not necessarily the presence of uterine contraction. So we actually did a uterine peristaltism study in women with or without adenomyosis. The difference is actually the coordination of the peristaltism. The contractions are more uncoordinated in women with adenomyosis, and so trying to suppress them with atosiban or by other means may not necessarily actually eliminate the problem of uncoordination because the contractions themselves do not seem to or do not actually interfere because women tend to get pregnant in the absence of adenomyosis, and they do have peristaltism anyway.
Okay.
If you allow me, I think that
yes.
now, if you allow me, I think that, in cases of adenomyosis to decide over treatment, in cases of patients that they underwent let's say ICSI or maybe IVF, it's a very good idea if you discover adenomyosis during ultrasound to go for an hysteroscopy to see if there are signs, of impairment of the endometrium. So if there are signs of impairment of the endometrium, then you have to decide, over probably the use of GnRH analogs, extra long protocol, the antagonist. If there are no signs, then you can go as Vasilis proposed as the usual cases. So I think hysteroscopy is a very good tool to see what is the impairment of the endometrium if you have cases with adenomyosis, to decide over treatment or not, in the first IVF attempt and so or embryo transfer.
Okay, Ertan, especially I want to thank you. You canceled your program because of our webinar and you stayed with us. Thank you. Dear friends, your adenomyosis show was excellent, was amazing. Thank you, all three of you, for your excellent presentation again and your contribution. It was a truly enjoyable and educational session. Thank you very much.
Okay, yes,
Any
and
last?
we thank you again for organizing this webinar, which I thought was quite informative overall. Not necessarily because of my presentation, but I enjoyed listening to the two other presenters.
Yeah, I am also interested in adenomyosis surgery. This night, believe me, I learned a lot of things from you. Yes, last sentence from Grigoris and Vasilis.
First of all, I would like to congratulate once again for your this initiative. I really enjoy, this webinar. It was of very high quality, not of my presentation necessarily, but also, from the discussion and, from the other speakers and your coordination. I'm really very happy and honored to participate. Congratulations again. Thank you very much.
Yeah, thank you. Vasilis?
Thank you for the nice choice of topic. And of course, I fully agree with the nice environment, and we enjoy it very much, all of us. And I would like to invite you again, each one of you, to come to Krakow. We will have much more interesting things on adenomyosis, including imaging, surgery, live surgery, etc. So we are looking forward to welcome you all in Krakow. Thank you, Recai, once again.
I am trying to bring with me at least 30 surgeons to Krakow. Don't worry, I will do my best again. Thank you.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye.